This episode of Between the Lines with FGI is brought to you by the American Society for Healthcare Engineering, optimizing healthcare facilities. Welcome to Between the Lines with FGI, a podcast brought to you by the Facility Guidelines Institute. In this podcast series, we invite you to listen in on casual conversations related to health and residential care design and construction. Coming to you from Washington State is FGI's very own John Williams, Vice President of Content and Outreach, Chair of the 2026 Health Guidelines Revision Committee.
And joining us today from St. Louis is FGI's very own Bridget McDougall, Associate Editor here with FGI. And like we usually are, we're very curious about the design of healthcare environments, and we want to talk about it. So, Bridget, are you ready for today's trivia fact?
Ooh, a trivia fact. Yes, I'm always
All
ready.
right.
What you got?
So you're in St. Louis, and
Yep.
across the river, the mighty Mississippi there, is the small town of Alton, Illinois? Altoon?
Alton.
Illinois. Okay. So Alton, Illinois was birthplace of a gentleman named Robert Pershing Wadlow, and he lived there from 1918 until he passed away in 1940. Do you, by chance, know who he was?
Okay, yes, because we talked about this before we started recording the episode.
Yeah, fair.
But also, I do remember seeing his photo in the Guinness Book of World Records when I was a kid. My favorite book, by the way. Did you used to read
Oh,
that?
I did.
Oh, man, it was the best. The delights of being human. I loved every part of it. But yeah, I remember this guy.
Yeah, okay. So for listeners, Robert Wadlow was the tallest person in recorded history, clocking in at 8 feet 11.1 inches.
Super tall guy. He was an 8-pound, 5-ounce baby, which is big to be sure, but not unheard of. But by age 8, he was already taller than his dad. So I'm 5'5", and Robert, or little Bobby, maybe, I don't know, was my height by the time he was 4.5.
Wow.
John? Yeah. He had a special desk made for him in elementary school to accommodate his height.
And certainly we're not meaning to make light of his size. He actually suffered with a medical issue. I think his pituitary gland gave out more human growth hormone. So we're not intending to poke fun, but, it is curious.
Absolutely. And, you think about him going through life at a height much taller than the average Joe or Bob or Jill or anybody. And there are a lot of accommodations that have to be made, like his elementary school desk. And it makes us realize that we as humans really come in all shapes, sizes, and abilities. And this prompts the question, how should our buildings, especially our healthcare buildings, respond to the needs of these folks?
Brilliant. And that is a topic that the FGI guidelines, soon to be the FGI facility codes, have been addressing for some time. And of course, we're talking about the requirements for individuals of size. We used to call it patients of size, but now individuals of size. And who better to talk about this than Dr. Marie Martin from the Department of Veterans Affairs? The VA has been a leading voice in advocating for this concept of safe patient handling for decades, and was one of the leading voices in the creation of FGI's patient handling and mobility assessment.
Yep. Or the FAMA, as it's known. So we've got the guidelines, the code, that require preparation of a patient handling and mobility assessment during health and residential care facility project planning. And the FAMA white paper that was published first in 2010 and updated as a second edition in 2019 was created to provide explanatory information about patient handling and mobility equipment and its uses and benefits, how to prepare a business plan for implementation of safe patient handling and mobility program, and ways to implement and promote such a program.
And to be clear, there were a lot of folks involved in the creation of this white paper, and please go take a look.
It's a free download, by the way, right? You can get it on our website, so we'll make sure to put a link there. But
Yeah.
This is absolutely free.
Yeah. Dr. Martin was a principal author of the FAMA alongside Mary Matz, both of whom FGI is incredibly grateful for, and especially for their dedication to patient, resident, and caregiver safety. So let's get ready to read between the lines with FGI. Ready to go?
Absolutely. Welcome, Dr. Martin. Thank you so much for being with us today.
Well, thank you so much for having me.
We're really honored that you took the time to spend some time with us today and talk about individuals of size and the tool that we have here to discuss. But before we get into that, tell us a little bit about what you do, how you arrived here at this point in your life, and just your background.
Sure. So I am the program analyst for the Safe Patient Handling and Mobility Program within the Veterans Health Administration. This is part of the Occupational Safety and Health Program. I came to the VA as an industrial hygienist. And when I had worked at the VA for about a month, my safety chief came in and said, "Hey, there's free money to put ceiling lifts up, and nursing doesn't have a person to do it. Do you want to do ceiling lifts?" And I said, "Absolutely." And I love it. I've been in safe patient handling and mobility ever since. And I get to help people in ways they can feel, which is super satisfying. So I come from industrial hygiene and safety. I did my research at the University of Washington. That was about 2008 when I joined the VA. In 2014, Mary Matz had me come in and work with her with the national program. And she ended up, as she retired, turning the program over to me for a couple years until they managed to hire the current program director, who is Tony Hilton. So I have gotten a chance to help the safe patient handling and mobility program managers of every VA healthcare system in the country and to learn about their problems and their victories. And we've managed to cut staff injuries by more than half and prevent a bunch of patient injuries while we're at it. It's a very satisfying thing I get to do.
Yes, thank you so much, not only for joining us today, but all of your contributions to this conversation. The VA has really led the research and the development of standards around this over the past couple of decades, even. In the late 2000s, the VA was a real driver in contributing this concept to the FGI guidelines and developing what we call our FAMA white paper that we use today. I'm wondering, Bridget, maybe if we could go through the basic information that's in the guidelines first, just to sort of orient our audience for what we're talking about and where it shows up in the guidelines.
Do you mind going on this journey with us, Dr. Martin?
Sounds fantastic.
Great. So we have these three major buckets in the guidelines around how individuals of size are addressed. And the first is that patient handling and mobility assessment that you mentioned. That patient handling and mobility assessment is required. It's a requirement to be completed as part of the safety risk assessment.
Yeah, so second, the projected need for all of those accommodations for individuals of size has to be identified during the planning phase. The guidelines require and prompt the governing body of an organization to do this planning part to identify not only the weight capacities that they plan to care for, but the number of spaces and where they're located inside of a building. And this is the governing body. This is facility leadership going through and identifying that based on demographics, history, what have you, and then handing that off to the design team to implement the decisions that were made there.
So finally, once you do the risk assessment and then you figure out the need, then you determine where these spaces will be needed. The guidelines then give specific requirements about those spaces that must be followed. Dr. Martin, the question that we get the most around this topic is what constitutes an individual of size? Can you give any guidance on that or talk about how you've seen facilities do this?
Certainly. We have developed a definition of an individual of size that has multiple definitions in one. It could be a person overweight by more than 100 pounds, with a body weight greater than 300 pounds, or a body mass index greater than 40. If you're talking about safe patient handling and mobility, a BMI of 30 is usually the threshold. And this could include people who are tall or muscular and not necessarily obese. We have been talking to a community weighing over 300 pounds that prefers to be spoken of as plus sized. And so if you hear me say plus sized, that's where we get that terminology.
And it's important to talk about those terms because we want to be sensitive and we also want to acknowledge that there are a whole lot of different kind of scenarios that you're talking about that may indicate the need of a special design.
Mm-hmm.
So you mentioned University of Washington. I know they have a sports medicine program where they're working with people who may be really, really tall. I'm thinking, football players,
Yep.
basketball players, but certainly lots of other folks, and how the building responds is important. All of those considerations factor in. We used to use the term bariatric in the FGI
Mm-hmm.
guidelines, and then we shifted to patients of size, and then we just acknowledged individuals of size as well, because it's potentially not just the patient, it could be the staff, it could be any sort of user of the built environment that we're trying to identify.
Absolutely.
So there's a sensitivity, and we've done that throughout the guidelines with all types of patients. We had that shift with behavioral mental health patients, which used to be psychiatric. So it is
Mm-hmm.
important to get the right terms, the right identifying language.
You bet. And there are multiple categories within the of size bucket. So it's often important to talk to your health informatics team about the rates of BMI and weight levels, because if you have someone above 300 pounds versus above 500, above 700, the accommodations start to look different when you get above 500 pounds. And so it's important to know, if you have a defined population, what are the rates of the higher weights and the higher BMIs?
And when you mention demographics, I mean, I think that's the next most common question that we get, either from being an authority having jurisdiction or being staff at FGI. How do I determine how many of these spaces
Mm-hmm.
will be needed? And you mentioned demographics, but you also mentioned the types of services provided. So I imagine if you live in a particular area of the country, there's a demographic kind of calculation that goes on there. But if you
Absolutely.
are maybe like a sports medicine program or you have a bariatric surgery center, that also factors in. How do you suggest that people kind of approach that question of volume?
You've made an excellent point about people showing up to different types of services at different rates. Within VA, we can predict who is in our catchment area. We can do some statistics on that. You can have a visitor show up at your emergency room, and emergency and urgent care services have to be able to give the medical exam to someone who needs help now. So they probably have the most onus on them to make sure that if someone comes in, there is a way somewhere to serve them. The other pattern we see is that while people who are plus sized use outpatient care or need outpatient care to prevent them from landing in inpatient care and the emergency room, they don't always come in for outpatient care, especially if they think they can't be served or will be judged. And so, if you are going to create places to serve individuals of size, making that clear might help. There are common practices we do where we designate what kinds of care can be done in a procedure room, and we'll have a procedure room with the extra space and the extra capacity connected to a bathroom that is also large enough, and to have it designed to be able to do a lot of different types of care. However, if they need something like dental care, which requires even more specific equipment, that's harder to accommodate. When you get into inpatient care, we know that people who are plus sized tend to use healthcare more often. They're more likely to be admitted to the hospital. They're more likely to be in the intensive care unit. And so those areas often need a higher proportion of rooms designated for individuals of size because the people who take them up are going to need to stay longer because of complications, because of difficulties with discharge. And this length of stay question is another thing that a facility can ask their health informatics team about and ask their staff whether they have found themselves needing more space designed for plus sized people. We've heard of facilities who are designing new bariatric space because they found that the space they had was always in use. There are differences in how you use it. I will say CDC found that the prevalence of obesity nationally between 2021 and 2023 was 40.3%. And since 2013, 2014, the prevalence of severe obesity, that's a BMI greater than 40, has been increasing from the 7.7% it was then to 9.7%.
So that sounds like there are a couple of different things to consider. There's not only the population demographic and the people in a catchment area, but it's the hospital or the system's own experience and historical data around not only the number of people, but the frequency of use. You also mentioned the types of services that you will see in a particular area. And you make the great point of emergency rooms and the requirement to serve and do that initial triage. And that's a requirement through EMTALA, which I think is the Emergency Medical Treatment and Labor Act. General expectation that if you show up at a hospital, you get that basic assessment and treatment. So there's a whole lot of things that factor in, not only the data, but the experience of the people who work inside of your facility. So you mentioned your health informatics personnel, but also the nurses and the people who actually work in the space who can give you not only the data, but the anecdotal kind of information that really layers in. So we said governing body gets together and makes that decision, but who else, as part of that multidisciplinary team, would we think needs to be involved in this conversation?
I do really want to go back and answer that, spend a little time there, because we don't say in the FGI code, we don't say you have to have X number of rooms to accommodate individuals of size. We just say you determine, and then once you determine, this is how you do it. And some folks that might be new to building healthcare facilities really are not sure where to go to get that information. Where do I go? How do I do it? Who should they look for? Let's say it's an outpatient facility that's being built and they don't have a hospital system right there at their disposal to have those discussions. Where would they go?
If you are building new and you don't have any people who already work with this population, it's brand new, I would be looking at the population data for your area. I would look at where you're going to refer someone if you can't serve them. Because if you mention no hospital system right there, some of our more rural areas have more difficulty referring someone to please go somewhere else if the somewhere else is 2 more hours away. And there is, I think, some perception in some of the people who end up planning for the first time that says they don't see people weighing over 500 pounds. And that's common because a lot of public buildings and services have narrower doors and don't necessarily accommodate the wider wheelchairs. If there is a facility that has wound care specialists, that is definitely someone you want to bring in. because they are very likely to be in contact. If you have a bariatric surgery center, they're interesting people to talk to. There are bariatric interest groups, conversations, there is a conference. There are places to get more information. If you have a safe patient handling and mobility person who is a specialist on your team, they probably have ways to be tied into the broader SPHM community through professional organizations. But if you're building from new, I'd say start from your percentages and then ask the what if question. What are we going to do if that person in a 52-inch wheelchair rolls up?
So when you talk about gathering data or looking at that data first, are we specifically talking about going to the CDC website and looking at your particular state, or are there other data points?
So I know CDC has state level numbers. For anything more local, I am not sure whether that data exists. If you are part of a larger healthcare system, we have some national data we can pull to tell us where the people are who have weights over 700 or 900 pounds. And so we can say, hey, facility, you have in your population 20 people weighing over 500 pounds, and two of them weigh over 900.
You mentioned that there's a community of people interested in safe patient handling and advocates for plus size patients. I wonder if we could get those links and put them on the webpage for this episode.
Certainly, I am a member, but I am not on the board of the Association of Safe Patient Handling Professionals. So I can't endorse any of these organizations, but the Association of Safe Patient Handling Professionals is a large organization for safe patient handling and mobility that does have a community and education events. I'm also putting a conference link in the chat to a bariatric solutions conference. And again, I've learned. I can't endorse it, but have had good experiences there.
Perfect. Thank you.
When we look at accommodations for individuals of size, it's grouped into two areas. One is making sure that there is enough space and enough weight bearing capacity. But then the other considerations seem to be all around the caretakers that will be assisting that patient. I read a lot of information that was provided in that FAMA white paper about the risks of caretakers and injury. Can you speak to that a little bit?
Absolutely. There are manual transfer and assistance methods that are still taught to students today in nursing school that are not safe because they expose staff to the forces of lifting someone over 35 pounds and or lifting, pushing, pulling in bad positions. This breaks down people's backs and arms and shoulders and necks over time. Sometimes the injury is sudden, but sometimes it's cumulative. One of the things that can happen is that if you have the proper equipment to support your patient to get up, to be able to sit upright in a chair, to stand and walk with support so that they can start from wherever their mobility is and have the support. If they can do that every day that they're in a hospital, they're more likely to be able to go home. Now, facilities that try to keep people mobile by moving them around by hand risk hurting their nurses and their therapists. And you may know there's a shortage. Conserving that resource so that instead of having to have 5 people to get someone up, you have a few if we can use the lifts and the air-powered technology and the smooth repositioning sling to move people around so that they get to be mobile and people don't get hurt doing it, the staff win, the patient wins, the facility wins, the length of stay can go down, the discharge can be more often to home instead of skilled nursing. There are so many benefits from a safe, early, and continuous mobility program for the staff and the patient, as well as bringing them to their maximum safe level of mobility.
One of the most eye-opening things that I remember about first reading the FAMA white paper was that 35-pound recommendation of the maximum weight that a healthcare provider should be lifting. And that's not a lot. If you think about it, that's, potentially 5 or 6 people all working together to do one of these transfers.
And the thing about trying to split a transfer between 5 people is that it's never equal. There
Hmm.
is always someone who has the heavier part. There's always someone who pulls first. If you're trying to push a bed, there's always different forces in different directions on different people at different stations. One of the great things I've seen is even emergency providers taking some of the portable battery operated air powered equipment out with them so that they can use it in the field.
I think the statistic that I saw in the most recent version of the white paper is that 80% of nurses at some point are injured by one of these safe patient handling events, whether it's that immediate injury or the cumulative injury of doing this work over time. I know that some governmental organizations are looking at this, and I know we have listeners in the UK where I think it's the UK and Australia who have adopted a no lift policy. But at least in the States, it seems like that becomes a state by state decision. Do you know of any national level effort to try to protect staff in this way?
In addition to the state laws, which vary as you mentioned, OSHA has published inspection guidance for inpatient healthcare settings back in 2015. And they have included a set of questions that their inspectors ask about ergonomic risk factors relating to patient and resident handling. That is the most uniform enforcement because OSHA can enforce safe patient handling if they choose to under the general duty clause. Now that patient handling is a recognized hazard that can lead to severe injury. The American Nurses Association published their interprofessional standards. The first edition was in 2013, and that really allowed OSHA to be able to publish that inspection guidance.
Well, we live in this interesting world, FGI does, of code, right? Of minimum
Mhm.
standards, required code. And then we've got the individual size accommodations and all of the questions to ask yourself when you're building a facility and helping to keep patients and caregivers safe. And just because you might open the code and only find a few sentences there about what is required, with that come a whole host of considerations.
And that's such a good distinction because one of the great things about working with a group to identify patient safety problems that could crop up before you design them is that if you identify the patient safety problem before you build it, you don't have to pay for the safety problem or the rework. There are a lot of times I have heard, well, if it's not required, it won't be done. However, there are cost implications of the patient safety problems that you can prevent. You end up in intangibles sometimes if you're talking about recruiting nurses and therapy staff by saying, look, here we have the equipment that you can get more done without hurting yourself. that becomes a little bit harder to quantify on the cost. But there are facilities, including some private ones, who have seen the worth to adopt these practices into what they do. And safe patient handling and mobility is as much about convincing people that they will need it as it is about the requirement.
And that's so often the challenge that we get when we talk about requirements that aren't necessarily subjective, but start with this subjective kind of conversation about, well, what do we really need? And where do we, as a facility or a culture, where do we want to go? What kind of infrastructure do we want to provide for not only patients, but our staff in the future? There's always the challenge of that first cost and quantifying the value that some of these investments might make. But when we talk about the types of equipment that we typically see to support safe handling and mobility, we always talk about lifts. And
Mm-hmm.
there's two major types of lifts. There's the ceiling mounted permanent ones and the ones that roll around and move around. Do you have a thought on the differences of those two types of lifts and where you would want to see one versus the other?
Absolutely. In VA, we did research over 20 years ago now where we found that ceiling lifts in nursing homes and spinal cord injury, long term care, hospice, those sorts of areas made back their cost in 4 years.
Wow.
And that's just on staff injuries. So we have a practice where what we expect in areas where you are very likely to see people who need full body assistance that are not mental health, that are not residential. I'm talking med surg, ICU, and all sorts of community living center, possible exception of dementia. We put a ceiling lift everywhere. We are not getting out of floor lifts that way, but it does mean that the floor lift becomes your emergency equipment.
Right.
Now, when you take people walking, there are some of these pieces of lift equipment that have to be mobile. And I have colleagues who have put ceiling lifts up in hallways. I also have a lot of people I've seen walking around in their walking slings with their floor based lifts or their sit to stand lifts, which can walk. There's a pretty wide variety now. And so you want them to be able to walk to the bathroom if they're in that walking sling. You want them to be able to stand in front of the mirror and do their activities of daily living. You get into some L shaped bathrooms and it gets interesting.
Hmm.
But my favorite design is a traverse ceiling lift. I mean, ideally, you've got the fixed rails recessed so that there's not too much hanging down out of your ceiling. Of course, you have to watch out for the sprinklers and all of the other things in the ceiling, but
Mhm.
you can hide your lift in a cabinet when it's not in use. I have facilities using switches and turntables so that you can get to both the toilet and the shower area because falls happen in bathrooms. And it's very hard to navigate a floor based lift in a lot of the bathrooms we see.
And so much space is required there. Even in our guidelines, we end up with a much larger transfer side where you're relying solely on those mobile lifts.
So there's a lot to see and learn here as far as equipment.
The VA has published a safe patient handling and mobility design criteria document through its technical information library from
Nice.
construction and facilities management. And so that's going to have some pictures of how things can
Uh-huh.
interact and lift designs that are possible.
This is really fascinating and really helpful, Dr. Martin, because I'm used to seeing it from the code side, which is how much space is needed in the facility to accommodate the actual equipment itself and what that equipment is. We don't specify or even mention that.
One thing I'll say about storage is that storage needs charging. Storage needs to be accessible to where people are. I love nooks in hallways so that you don't have to navigate a door. In the guidelines, you will see that you have a certain number per number of patients. It's one per 8 to 10 who are expected to be fully in need of complete assistance. And when you are in a long-term care facility, that's a lot of floor lifts to store. And so you have to think about a lot of storage. I've seen a lot of storage disappear from plans between design and actual building because they take the storage and make it something else. If you can't store it, you can't use it.
Perfect point. But you also mentioned those travel points between a patient room and a procedure room, or a patient room and a discharge point where you're needing not only, the flooring, the transitions, the door width, all the way through the facility.
Indeed, the path of travel is so important, especially for not just people with disabilities, but plus sized people, and especially plus sized people with disabilities who need to be maneuvered around. So there are turning radii, there are making sure the doors have a wide enough width, and the elevators allow you to get in and turn. But if you have carpet on your path or a slope on your path, that is going to be an additional risk because it's going to take more force to traverse that path. And I've seen people injured taking people down the slope from the front door or on the long slope between buildings or pushing on carpet.
Any last piece of advice or any last thoughts that you want to leave us with?
If you are looking to design for people who are plus sized, there are people who consult who are plus sized who can give you everything from experiences to fit checks. If you have questions for what VHA has as experience, you are welcome to contact VHA SPHM at va.gov. We have a whole bariatric guidebook that is on our intranet, but that we are happy to share with people who want it. And
Very
I am
nice.
just glad to see people talking about serving people of all sizes and getting them access to medical care that serves their needs while protecting both them and the staff.
Well, we sure appreciate people like you, like Mary Matz, making it their life's work to keep people protected, to keep people safe, and to allow the same healthcare opportunities to anyone, regardless of size.
It's great work that I am very glad to get to do with people I learn with every day.
Thanks so much for sharing your time with us today, Dr. Martin. Best of luck, and we hope to hear new and exciting things soon.
Thanks for joining us for another episode of Between the Lines with FTI. Do you have an idea for an episode, or are you interested in sponsoring one or a series of episodes? Get in touch with us by sending us an email at podcast@fgiguidelines.org.
Yeah, we got some fun stuff coming up. Topics include plumbing, the safety risk assessment, and quench pipes.
As always, many thanks to Neil Kane and the Neil Kane Trio for the use of his song, Skip to My Lou. You can find it on the album of the same name.
All right. Join us next time as we go Between the Lines with FGI. Goodbye, everybody.
Bye. Hey, John.
Yeah.
So I was reading about Robert Wadlow. What did you say? What do you think it would be?
I thought Wadlow.
Wadlow. Yeah, that's
Wadlow?
good.
Maybe.
Anyway, the world's tallest man that we mentioned at the beginning of the episode, right?
Yep.
And during an interview, he was asked if he was ever annoyed that people stared at him, and you know what he said?
No. Tell me.
This is true. This is not a joke. This is, I think, shows his good humor. He said, "No, I just overlook them."
What a joy.
Yeah, right?